Good morning, good afternoon, good evening, wherever you are. Thank you for joining us for this session on small vessel disease and vascular dementia. My name is Dr. Sokhi. I'm a assistant professor in adult clinical neurology at the Aga Khan University Medical College of East Africa. I'm grateful to the organizers for inviting me to give this talk. The epidemiology of dementia is changing and is increasing as per the Global Burden of Disease study. As you can see here, the areas in orange, amber, yellow are in the MENA region, but Kenya, where I come from, and East Africa are not very far behind. And this is going to continue to be a continuous challenge for those of us dealing with patients with dementia. What is dementia? It is a disorder with cognitive decline, not just with memory, but in a number of domains: language, executive function, complex attention, motor skills, and social cognition. And you need at least one domain of these to be affected, and which represent a decrease from a previous level of functioning that can impair daily activities, as per point B here. And then there's C and D to exclude other reasons why someone may have a memory problem. So just a bit of history about vascular dementia, the historical perspective. First described as a post-apoplexy in Thomas Willis's book in the 17th century, and that's the book there, Anima Brutorum, and it is thought to be due to brain congestion and cerebral hyperemia in the 19th century as a cause of this. However, in the 20th century, Binswanger described subcortical encephalopathy due to this widespread vascular disease. And in 1974, the term of état lacunaire, which is the appearance you see on scans with lacunar infarcts due to cerebral arteriosclerosis, as it was then known, it was replaced with this new term of multi-infarct dementia, where vascular disease is responsible for dementia through multiple small or large cerebral infarcts. However, vascular dementia was coined and has been used since for all these terms since 1993 and has its own diagnostic criteria. And that's the term we'll be using from now on. And I will use the acronym VAD for that. So in terms of definitions, in terms of vascular dementia, you can have post-stroke dementia. You can also have vascular cognitive impairment, but not have dementia. So that's called VCI, which is essentially mild cognitive impairment, but due to vascular causes. And you can also get post-bleed cognitive dysfunction, e.g. after a subarachnoid hemorrhage. There are imaging criteria which involve large or small vessel ischemic changes, microbleeds, microinfarcts, the genetic causes, and there's risk factors for vascular dementia. And the types of small vessel disease that we do have are the classifications are shown here. There's the small vessel disease from arteriosclerosis, amyloid angiopathy, genetic and inherited small vessel disease, and I'll show you a table of this in a moment. Inflammatory conditions such as vasculitis, be it primary or secondary, or infectious, venous collagenous diseases, and other diseases that can cause angiopathy, such as radiation for cancer. Here's an example of dementia after stroke. And this meta-analysis shows that in the top table, in the main two papers, especially those circled in blue, that the prevalence of dementia after stroke in the succeeding 3 to 6 months was almost in 1/5 of the population, if not almost a third. And then if you exclude those who did not have dementia before they had the stroke, the number is about 20%, so about a fifth of them. So this means that a good number of people get dementia after stroke and is a significant cause of it. When I talked about the genetic diseases, it is interesting to note that out of all the genetic vascular diseases that are present, most of them present with dementia too. For example, all the ones listed here, the only two that are not classically associated with dementia are those at the bottom. In terms of the neuroimaging markers, these are what we look at. On the left-hand side here is the what we see on MRI scan in terms of the lacunar changes and white matter hyperintensities, usually graded on the Fazeka scale, 0 to 3. And this depends on whether there's periventricular white matter hyperintensities. If they're absent, pencil thin, there's a halo, it's irregular, or whether there's deep white matter that has the same changes. Then you have perivascular spaces based on a 4-point visual rating scale. You have microbleeds, which can be picked up on the gradient echo, and the other markers using SWI, which can tell us whether they're focal or disseminated, and then cortical microinfarcts that can be found on more dedicated imaging. And the types of small vessel disease are either hypertensive, which is type 1, or there's type 2, which is the cerebral amyloid angiopathy, and you can score them accordingly. So just moving on, these are the changes that are described. So on the Fazeka scale, you can see grade 0 to 3 in the top, in the periventricular white matter changes, and the deep white matter down there. So there's caps of pencil thin lesions, as per the white arrows here, smooth halos or irregular deep white matter changes, and the other deep subcortical deep structures being affected here with punctate foci, confluent foci, and large confluent areas. And these in themselves can show how one develops dementia over time based on either pathology, from lacunar infarcts to hyperintensities, microbleeds, and then eventually you get atrophy. And these are the key findings we find in vascular dementia. It's important to note also that pathologically, if you look at the areas of the brain, which here are indicated from number 1 till 8, the findings are the same whether it's due to sporadic or familial Alzheimer's disease, in terms of small vessel disease, which brings me to the point of the fact that Alzheimer's and vascular dementia usually do coexist, although not always the case. And you can see the same changes here, 1 to 8, with your perivascular deep white matter lesions in image 1, lacunar infarcts here in image 2, and white matter infarcts in image 3, microinfarcts here on highly dedicated imaging on image 4, lobar or deep microbleeds or hemosiderin staining, as you can see at the graded echo sequence here, number 5, intracranial hemorrhage due to cerebral amyloid angiopathy, superficial siderosis from previous bleeds, and then increased perivascular spaces as seen in image 8 here. There's also the thinking that the small vessel disease causes what we call a glympopathy. It's called the glymph node or the glymph system. It's a lymphatic system within the cerebrovasculature on a minuscule scale, and it's thought that this is also affected progressively in small vessel disease and contributes to the vascular dementia. So a new model for stratifying dementia, the risk factors are here. Apart from what we normally know of, which is the amyloid plaques and tau and tangles, is small vessel disease, and it seems to probably be there from the beginning as a cofactor leading from normal cognition over the years to mild cognitive impairment and then eventually to dementia. It's important to note also, given the places we are currently practicing in, that there seems to be some racial differences too in terms of pathologies. So for example, here's a paper on Alzheimer's disease and related dementias in those of African American or Hispanic women. And I'll draw your attention to the middle here. That is that in African Americans, it was greater than non-Hispanic whites to have neurodegeneration in the majority of cases, and less so in less population-based studies where the non-Hispanic whites had greater changes. And also of significance is the concurrence of small vessel disease in this population, although this seems to be pretty much the same in the non-Hispanic white population too. So there seems to be some racial differences in terms of dementia and small vessel disease. But vascular dementia is multifactorial. There are the non-modifiable factors here, which is age and race, genetic variants, but also modifiable risk factors such as your non-communicable diseases, diabetes, hypertension, dyslipidemia, and lifestyle factors as well that lead to large and small vessel disease, macroinfarcts, lacunar infarcts, and white matter changes. And eventually, this leads to vascular cognitive impairment and dementia over time. And this is from the Lancet Working Group on dementia, showing that that dementia is something that one gets risk factors for early on in life, and these are the percentage contributions to the development of dementia over time. In early life, it's due to less education. In midlife, hearing loss, traumatic brain injury, hypertension, excessive alcohol consumption, and obesity. Um, and therefore, it is important to address all of these. And an article in the BMJ does suggest that this early impairment of cognition is induced to this disruption of the glioneurovascular units in the brain. Neurovascular dysfunction may promote both early vascular and neurodegenerative cognitive impairment, and therefore, vascular risk factors such as diabetes, midlife hypertension, obesity, physical inactivity, smoking are associated with the development of vascular dementia and Alzheimer's, and therefore there needs to be some intervention to help in terms of lifestyle modification. Although the evidence for this is still a bit insufficient at present. But I'll talk about the management and the evidence behind treatments for vascular dementia in the next few slides. So what do you do when you're confronted with a patient with vascular dementia? You need to categorize first whether they have normal cognition, do they have mild cognitive impairment, or do they actually have dementia as per the diagnostic criteria. But it's also important to determine whether they've had any previous history of strokes or TIAs, and assess for risk factors such as smoking, diabetes, blood pressure, dyslipidemia, and atrial fibrillation, particularly, and must do a baseline cognitive function. Ideally, as we use in this part of the world, it will be the Montreal Cognitive Assessment, but if possible, a formal, full neuropsychological assessment at baseline would also be very useful by a trained psychologist who can offer all the battery of tests to assess someone's brain function. But it's also important to capture the activities of daily living, such as the Cambridge score or inventory that can be used to assess how impaired a patient with dementia is. And then further workup is determined by what kind of history and examination you do find. So, for example, embolic or cortically based infarct found on MRI scans or the CT scan would warrant you to look further for other causes of stroke disease. So, looking at cerebrovascular imaging, both intra and extracranially, and cardiovascular workup in terms of prolonged ECG monitoring and a 2D echo. But if you see instead that this is more cerebral amyloid angiopathy with gradient echo changes such as microbleeds or diffuse hemosiderin staining, then it may make sense to actually consider stopping antithrombotic or antiplatelet agents and maximize blood pressure control. And there is evidence behind this in terms of blood pressure control as per the trials here. So, for example, the CIST-EUR study, which is systolic hypertension in Europe trial, aggressive blood pressure management was associated with a reduced risk of developing dementia compared to placebo. Similarly, in the PROGRESS trial, which was parenteral protection against recurrent stroke study, cognitive decline occurred in 9.1% of patients on antihypertensive medications and in 11% of placebo, which is a significant difference. In the FINGER study, which was the Finnish geriatric intervention study to prevent cognitive impairment and disability, this investigated multi-domain interventions that included vascular risk factor monitoring and demonstrated a decrease in cognitive decline over 2 years. In contrast, there are several studies that have failed to demonstrate reduced risk of dementia or cognitive decline with vascular risk treatment. But the PREDIMED trial, which is the prevention with Mediterranean diet study, shows through a randomized control trial that a Mediterranean diet versus low-fat diet, it reduced the incidence of cardiovascular events and was associated with improved cognitive function overall. So looking back to the risk factors that predispose patients to or the population to dementia, here are the percentages again from the Lancet Working Group. And smoking, depression, social isolation, physical inactivity, air pollution, diabetes have the contributions. And all these factors that we've talked about are potentially modifiable, but only account for 40% of what drives dementia. So a lot of the factors are not modifiable. And this infographic here shows the things that do need to be addressed when assessing someone with dementia, particularly vascular dementia. And this came out in the recently commissioned Alzheimer's World Report from 2021. And it's important to also think about other factors such as previous head injuries, lack of social connections, any comorbid depression, that can also be addressed to help reduce the risk of dementia. In terms of treatment, as per any other dementia, there's education and counseling for and support for patients and caregivers, home safety evaluation, and advanced care planning. The American guidelines also suggest cognitive rehabilitation, particularly those who may have had cognitive impairment after, for example, a bleed or a stroke. There is evidence for aerobic exercise 3 times a week for mild vascular cognitive impairment. And there's mixed results from the trials that have been done on the acetylcholinesterase inhibitors and memantine. So they're not FDA approved for vascular dementia. But given that Alzheimer's disease does occur in a proportion of patients with vascular dementia, it could be logical to use them if you suspect that to be the case. Importantly, there are other things that need to be addressed, such as the neuropsychiatric manifestations of vascular dementia, and depression, anxiety can be addressed with antidepressants. But importantly is also pseudobulbar affect. This is a meta-analysis of functional MRI studies on patients with subcortical vascular cognitive impairment, and there was significant reduction in the frontal lobes, which explains why a lot of these patients do get this pseudobulbar affect as well. So in summary, dementia is increasing globally, and that also includes vascular dementia due to the increase of the non-communicable diseases in the developing world. Vascular dementia does occur together with Alzheimer's, but sometimes it can happen on its own. There are some regional and possibly ethnic and racial differences and predispositions based on global studies. The assessment of a patient with vascular dementia is as for any dementia patient, but additionally, we need to look for risk factors for small vessel and large vessel disease. And there are specific markers on neuroimaging and considerations if there's cerebral amyloid angiopathy and in terms of reducing or stopping antithrombotics. But because of the multifactorial cause of vascular dementia, it requires a full lifestyle evaluation of the patient and a holistic view that involves both the patient and the family. There's no specific medications that are warranted for vascular dementia, but it could be you could use the acetylcholine receptor inhibitors such as the memantine and donepezil if it is suspected that there is concurrent Alzheimer's disease.